So, welcome to a codathon for CPT coding, where I'm going to focus on week number 1, which is really learning about the CPT coding system. Now, I am assuming that if you are in the CPT coding class, that you've actually had other coding classes. So you understand some of the concepts of the coding process, but now it's just a matter of learning and manipulating through the CPT system. So I know that there was a live lecture on last Sunday. So this codathon is not meant to duplicate what took place in there, but to take that information and go to the next level. And so that's why we're going to focus on actually locating the CPT codes. But before we do that, I want to make sure that everyone has their CPT manual with them. Okay. And what about Wendy? Wendy, you have your CPT manual with you? Okay. Um, so first thing first, let me tell you that um, in our course syllabus, it mentions that you guys have a standard edition of the 2015 coding manual. And I will tell you that I actually have a professional edition of the CPT manual. And the big difference is that the professional edition of the CPT manual has more color to it, and it has some references to different types of references that support the CPT coding system, which I'll talk about shortly. But the setup is the same, and I just want to make sure that everybody understands how the book is set up. So if you open the inside cover of your CPT manual, on the left-hand side, the upper left-hand corner. Okay, Wendy, you have the professional. And I will tell you that I have the last 10 years of CPT manuals. And so since we are using 2016 in the industry, that is actually the one that I have in front of me. But so I won't be able to give you any page numbers, but definitely you'll still be able to code the scenarios that we're going to look at tonight. So the inside cover of your CPT manual, there's a couple of things I want to point out. Number one, in the upper left-hand corner, you see symbols. These symbols are used throughout the CPT manual to provide information only. They are not added with the code, and I'm talking about just the symbols right now, but they're not added to the code. Um, they they represent. Let's see something. Oh, look! Can you see me? Oh, I like to have too much fun with technology. No? Let's see. What about now? Can you see me now? Hi. Okay, so you're probably going to see my head go up and down because I'm going to look at my book. So in the upper left-hand corner, you should see the different symbols. The symbols are used for informational purposes only, such as a code is a new code or a code is a revised code. Now, below the symbols, you have modifiers. And I know in the week 1 live lecture, Professor Clark actually went over what a modifier is. And she gave you an example of how modifiers are added to the codes. I think next Friday, I can't do this every Friday, but next Friday, what I will do, and I'll give you guys a heads up now, I will do a codathon where we do a modifier challenge where I give you the scenario and you tell me what the modifier is. I think that will be fun. Just because I think the more you practice with the system, the easier it becomes. Okay, so um, the rest of the page focuses on modifiers, which again, in the coming weeks, you'll learn more about the modifiers and when you use them and when you don't use them. But on this week, you've been reading the chapter in the book that talks about what CPT is and how it's organized. So let's review. Number one, everyone should know at this point that the CPT manual is divided into 3 categories, with category 1 representing the main portion of the CPT manual. It is the portion that you're going to spend pretty much all of this 7 weeks now working with. So the category 1 is further subdivided into 6 sections. These are the 6 sections that you're going to be coding over the course of your 7 weeks. So let's take a look at those sections. In your book, again, I don't want to give the page numbers because you guys all have different books and I don't want to get into that. But the very first page I want you to look at is where your evaluation and management section begins. Okay, and let me know when you have it. And the way that you'll recognize it is that it's going to begin with the Evaluation and Management Services Guidelines. Page 1 in your book? Okay, page 1 in my book too. All right, so one thing that you should know. Okay, Wendy says page 4 in her book. So it really just depends on if you have professional or standard, so I won't give out the numbers. So each section of category 1, so there's 3 categories, each section of category 1 has guidelines that precede that section. So for example, if you look at whatever page you're on right now where the codes begin, you should see something that says, oh, classification of evaluation and management services. It's the written part, doesn't have any codes on it. You guys see that? Classification of evaluation and management services. In my book, it's green. Let's see, Wendy, did you see it yet? Classification of evaluation and management services. Okay, so at the beginning of each and every section, there are guidelines. So if you turn past the evaluation and management section guidelines, you'll see the first set of codes, and the first one says new patient 99201. So it probably is like on page, I don't know, my book is page 11. I don't know what page it's on in your book, but go to the page where right after the guidelines, you see 99201. Okay, so every section is preceded by guidelines. Now, in comparison to ICD-10-CM, ICD-10-PCS, the guidelines in CPT are spread throughout the manual, which is different because ICD-10-CM, ICD-10-PCS, those guidelines are in the front of the manual, okay? So each and every section has guidelines that are must read for that section. In your step-by-step medical coding book, the author actually takes the guidelines and kinds of breaks them apart. If you read the guidelines first, then read the chapter, it makes that information kind of stick in your brain a little bit more. And the reason why I say read the guidelines first, because in your coding manual, they're just going to give you flat out straight guidelines. Whereas in your textbook, the author is going to give you guidelines, examples, explain it a little bit more. Trust me, if you read the guidelines first, then read the chapter, it makes it a lot easier. Okay, so anesthesia is the second section of category 1. So let's go over to the anesthesia section, and you'll want to note that it begins with coding guidelines. Again, anesthesia guidelines, right? And then once you turn past the anesthesia guidelines, the first code that you should see is 00100. Everybody see that? Okay, so the first thing I wanted to point out is there are 3 categories to your CPT manual. The first category is the largest part, which is divided into 6 sections. And in front of each section, you have guidelines that pertain to that section. Now, I want you to find the surgery section, which is next. And of course, there are guidelines. But once you find the surgery section, I want you to find code 11000. Code 11000. 11000. And let me know when you have it. Hey, I should have looked at my hair before I turned on this webcam. I figured it would be cool for you guys to see a face with the voice. So code 11000. 11000. Okay, everybody find that? And it says debridement of extensive eczematous or infected skin up to 10% of the body surface. So what I want to show you is that I already talked about guidelines in front of each section. But within the section itself, we have notes that are known as subsection notes. So on the page where 11000 is located, you should see a paragraph that talks about debridement. Do you guys see that? Tracy, how about you? Okay, so that paragraph that is in front of the debridement codes is known as a subsection note. And the subsection notes provide guidelines on top of the section guidelines. So there are 6 sections to category 1. Each section is preceded by section guidelines, and within the section there are subsection notes. Everybody's following me? Okay, so the subsection notes really provide us with additional must-read information. So if you're going to use the debridement codes, you need to read the debridement subsection notes first to see if there are any notes that you need to be aware of, okay? So 6 sections of category 1: E&M, anesthesia, surgery, radiology, pathology, and medicine. The first thing that you'll notice is, why did the E&M code start with a 9, then anesthesia started with a 0. Then surgery started with a 1. I thought this code book was supposed to be like in numerical order. It is, however, because physicians are the primary user of the CPT coding manual, physicians don't always do surgery on patients. They don't always do labs. They don't always do x-rays. So the evaluation and management codes, which are office visits, consultations, nursing care, home care, those codes are listed first because they're the most widely used. So when you look at how the codes are organized numerically, once you leave evaluation and management, the rest of the codes are in numerical order, and medicine, which is the last section of category 1, has codes that start with a 9 as well. Does that make sense? Okay. So evaluation and management is the physician evaluating and managing the patient's care. The next section is anesthesia. This is anesthesia that's performed by the anesthesiologist or the certified registered nurse anesthetist, as an example. Okay. As you go through the next 7 weeks, we actually spend time on evaluation and management, time on anesthesia, a lot of weeks on surgery, and then we end with radiology, pathology, and medicine. So surgery is the largest portion of the manual. Oftentimes, it's said to be probably the most difficult because of just the nature of the operative reports. But here's the cool thing. Even though you've never coded CPT surgery, you have been exposed to operative reports, and you know that you got to dissect information out of those operative reports, just like you did in ICD-10 PCS. So you'll find that it might not be as difficult as you think to actually assign them. Okay, radiology. This is the section that's going to have things like x-rays, CT scans, MRIs, ultrasound, radiation services, nuclear medicine like bone scans for patients that we're thinking that they might or might not have osteoporosis. In the hospital setting, and I want to kind of tie this together for you based on what you've learned in other classes. You've heard us say, oh no, we're not going to code that because it's going to be captured by the charge master. What the charge master is actually capturing is a CPT code. And so what happens if we're talking about the hospital billing a radiology service or a laboratory services, it's the CPT code that's going to be captured. So now hopefully that kind of ties together. Oh, we're not coding that because it's captured by the charge master, like we've talked about in other classes. However, let me say this. If you work for the radiologist, you may not use a charge master. The radiology coder that's working for the radiologist, they may in fact have a coder that's utilizing the physical code book, but it just really depends. All right, pathology and laboratory. This is where we have tests for actually testing a specimen. In this section, we don't have codes really for collecting the specimen. For example, look for code 36415. 36415. 36415. Because I want this to make sense. 36415. Okay, 36415, collection of venous blood by venipuncture. So this 36415 is the code for collecting the specimen, whereas the codes that are in the pathology section are for actually testing the specimen. You guys see kind of like the connection between the two. Hey, maybe I shouldn't have turned this camera on because you can see my normal movements that I'm doing during my live lectures. So you guys see in the surgery section, we got a code that says the needle is going into the vein to collect the specimen. Whereas in the pathology and laboratory section, this is where we're actually testing the specimen being blood, urine, feces, sputum, vaginal secretions. Did I mention feces? So this is where we get codes for actually testing the actual specimen. And then the last section of category 1, I kind of call it the garbage can section. And the reason that I call it the garbage can section is because anything that we couldn't code in the first 5 sections, we can code it in the medicine section. So we're coding things like vaccinations. We're coding things like psychiatry services. We're coding things like physical therapy, occupational therapy, chiropractic services, non-invasive cardiovascular procedures. So in the surgery section, we have what are known as invasive cardiovascular procedures. Whereas in the medicine section, we have what we call non-invasive. So in the surgery section, you're going to have things like insertion of pacemakers, coronary artery bypass grafting. Whereas in the medicine section, you're going to have a code for testing a pacemaker. You're going to have codes for things like cardiac catheterization, where the catheter is being inserted in there into the left or right side of the heart, and dye is shot into those arteries and veins to paint a picture of what's going on with them. Also, let's see, EKGs, those are non-invasive cardiovascular procedures. Stress treadmill, where you're kind of like running on the treadmill for the physician to see, you know, how your heart does under duress, under stress. Okay, so for the most part, anything that we couldn't code in the other 5 sections, we code here. Now, in terms of do you code both in terms of the blood draw and the specimen? Typically, yes, but it really depends on who you work for. Because let's say the medical assistant in the office drew the blood, but the hospital lab is actually testing the blood. Does that make sense? How coding both would really depend on, you know, where you're working. Okay. All right. So I mentioned, and let's review, there are 3 categories to the CPT manual. Category 1 is the largest portion, and it's divided into 6 sections: evaluation and management, anesthesia, surgery, radiology, path and lab, and then medicine. Okay. The next 2 categories, you won't use them that often. However, we need to know about them. Category 2 is really specifically designed for our program that's called PQRS. I had to think about it because they keep changing the name. But PQRS is the Physician Quality Reporting System. And it's really where the government wants for us to report codes to see how we are managing things like chronic conditions. So if you have a patient, for example, that's asthmatic, there's a code that says you had your patient with asthma, you gave them a questionnaire today that talks about how their asthma, what their asthma status is. Another example is that you have given the patient counseling on stopping smoking. There's a code that says you had the patient fill out one of those depression scale forms. The reason that these codes are used is to track how well physicians are managing patients' chronic conditions, amongst some other things. Now, these are optional codes. Typically, the hospital is not reporting them. The physician may report them. The insurance company actually gives them some incentive monies to report them, but some doctors don't want to use them because they're like, wait a minute, that's a way for the insurance companies to be all in my business, right? And there is speculation that at some point those codes are going to be mandatory to be reported. So you don't have to worry about them if you have a job working for the physician office. The ones that they actually report, if they will report them, will be a small subset. So it's no major deal. Okay, and then the last category, category 3, is for emerging technology. And emerging technology is the latest and greatest technology that's out there today. So it could be, a new way to do a procedure. For example, back in the day, procedures were open, right? They just cut you from end to end and then they do what they got to do. Whereas today, we can do things using scopes where we just make the 2 little incisions. You remember from ICD-10 PCS when we talked about percutaneous. So there is so many different ways that they can do procedures today. They don't have to be open. So when we get a category 3 code, it's like the latest and greatest way that they can do procedures. Now, you may have read this week that there is sometimes a need to report what is known as an unlisted code, because we don't have a code that accurately describes that procedure. Here's the rule of thumb. Before we use an unlisted code, we have to check and see if a category 3 code is available. If a category 3 code is available, we use it. If a category 3 code is not available and we use an unlisted procedure, what's going to happen is that we have to submit what's known as a special report. The special report, and this is more along the lines of real world, but unlisted codes don't have reimbursement attached to them. And so what happens is that the insurance company decides on a case-by-case basis how much they're going to pay for the procedure based on what's known as the special report, which generally is the operative report. But if you read in chapter, I don't know what chapter it is in the step-by-step book, but reading that chapter, when they talk about special reports, there are 6 things that have to be included in that report. We have to know the nature, the need, the extent, the time, the effort, equipment that was necessary to carry out that procedure. And then based on that operative report, the insurance company decides pretty much how much they're going to pay the insurance company that on today, or the provider on that day. So again, category 3 codes are codes that we can use for reimbursement. We use them when we're trying to code a procedure that represents the latest and greatest technology out there. And if there is no category 1 code available, no category 3 code available, then you use a unlisted code, which is actually a category 1 code. All right, so let's talk about, now that we know our 3 categories, we know that the largest portion is category 1, which are those 6 sections. Now let's talk about how you actually locate a code, because that's usually the most challenging process for when you use a coding manual. So in your coding manual, in your CPT coding manual, locate the index, which is in the back of your CPT manual. And in fact, go to the page that says instructions for use of the CPT index. So it's the kind of like the pages that precede the index. And again, I didn't want to give the page number out. You both have page 743, but Tracy Johnson may have a different page number, and I definitely have a different page number. So as long as you found it, that's okay. So a couple of things that you need to note that are on that page for instructions for use of the CPT index. Couple of things. Number one is that we start the process by obviously reading our medical record documentation. From there, we have to determine how we're going to look up the procedure or service that we're trying to code today. On your page 743, you should see something that says main terms. And then it says the index is organized by main terms. Each main term can stand alone or be followed by up to 3 modifying terms. Let's stop there. What do they mean by that? Each main term can stand alone or may be followed by up to 3 modifying terms. Basically, what they're saying is you got your main term, and then underneath, you're going to have options. Kind of like an ICD-10-CM, where we call them like subterms. So that's pretty much what they're talking about. Okay, but here's the one thing I want to make sure you understand. There's 4 different ways that you can locate a CPT code. So let's see the 4 that they tell us. Number 1, by the procedure or service. Number 2, by the organ or anatomic site. Number 3, by the condition. Number 4, synonym, eponym, and abbreviation. Now, the first thing that you're going to say to me is, well, when do I know which way to go? Like, when do I know that I can use the name of the procedure? When can I use the condition? When can I use the body part? You won't know until you start to look it up. So here is the rule of thumb. If you can't find it under one main term classification, then you have to go and look at another option. Does that make sense? So if you can't find it under procedure or service, you might have to go to condition. And there is no magical list, unfortunately. There is no magical list that tells you what term to use. It's something that you learn by trial and error. So you have the step-by-step medical coding textbook. You have the step-by-step medical coding workbook. The more you practice looking up codes, the easier it will be for you to locate them. All right, so a couple of other things that I want to point out in the instructions for use of the index. And then we are going to do some coding. This is the Codathon, but I listened to the Monday or the Sunday night live lecture, and I put together my slides, which I only have 20, and we're on slide number 11. I put together my slides to really complement what was already covered and, you know, not really to duplicate it. So let's look at modifying terms. A main term may be followed by up to 3 indented terms that modify the term that they follow. So let's look at the example. In the following example, the code for an endoscopic removal of the calculus from the urethra should be located by going to urethra, under urethra, removal calculus. Codes tell a story, right? So what did we remove? remove the calculus from the urethra. Now, this example tells us to start with urethra, but that's not the only way to locate a code. Remember, there's 4 ways to locate a code: procedure or service, organ or anatomic site, condition, synonym, eponym, abbreviation. Okay, everybody still following me? Is this making sense? Okay, now let's look at the next part that talks about code ranges. When you're looking in the index, underneath you're going to go to your main term and then your subterm. You are going to be given one of 2 options. You either are going to be given a range of codes, and how you'll know it's a range is because it'll have a hyphen in the middle, or you'll get a couple of codes. So looking at the example, esophagus reconstruction, they give you, let me turn my light on because I can't see, 43300, comma 43310, comma 43313. That means that all 3 of those codes have to be looked up to figure out which one of those 3 is going to be your final code based on the documentation. Does that make sense? Okay, and then the other type. So I told you that it's either a comma or it's a hyphen. So comma is like a couple of codes they want you to look up, and then hyphen is like this range of codes. So if you look at the second example, monitoring electrocephalogram, electrocephalogram 95812 through 95813, comma 95950 through 95953. Again, that means that you have to look up all of those codes and based on the documentation, determine what the code should be. Okay, the last thing I want to cover, this is very, 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 very important, and I think oftentimes can be the most confusing when you're doing CPT coding. And that is the use of what they're calling a space-saving convention. And I'm going to not use this example. I want to use an example. The page, the writing on this page is so small. All right. I want to show you an example in the main portion of the book, because this example is okay, but, well, no, let's just use this example. So the convention for saving space is typically used when there's like a subterm option. So for example, knee, exploration of, and then they list the codes. But then it can be knee, removal, and they list more codes. So you see how the conventions are designed to kind of save space, as opposed to listing them straight down, they list them across, and then we know as the user that we have to look up all of those codes that are there. So knee, exploration of, some code options. Knee, excision, and then some code options. Okay, that's one way that they save space, but I want to show you another way, and we're going to go into the main portion, because this is very, very, very important. All right, so I want you to find code 67036. 67036. You guys got it? 67036. Let me put the little timestamp on here so I can see when you guys say yes. So 67036. Okay. Another way, so I showed you how they save space in the index, but now I want to show you how they save space in the main portion of the book. So code 67036, if you notice, it's not indented, right? And it says vitrectomy, mechanical, pars plana approach. Vitrectomy, mechanical, pars plana approach. And then there's a little semicolon behind it. Everybody see that? Behind approach. Okay. Now, the codes that are underneath them that are indented over to the right, 67039, 67040, 41, 42, 43, are child codes of 67036. And what I mean by that is, whenever you have a code that is indented over, it relies on the description of the parent code above it that's not indented. So let me explain. 67039 reads as follows. Now watch me. Vitrectomy, mechanical pars plana approach with focal endolaser photocoagulation. Whenever you have a code that's indented, you read the description of the parent code up to the semicolon and then drop down and read your code. No, you don't report both codes. You're just using the description of the semicolon. So instead of them writing vitrectomy, mechanical, pars plana approach over and over and over again, they listed it once, semicolon, and then indented the rest of the types of procedures. Does that make sense? Okay, we're going to do another one. Look at code 52320. Yeah, so you're only going to report the code once. Look at 52320, and I promise we're going to do some coding, but I got to lay this foundation now so that you understand what you're looking at once you start coding. 52320. I have to turn my light on to see. Okay. 52320. So you should notice 52320 is what we call the standalone code. And then 523, 25, 27, and 30, those are like the indented codes, but those are the child codes. So let me review these codes with you to make sure you understand. Oh, do you notice how 52320, 52320 is indented over to the left, but also 52332 is indented over to the left? So 52320, look at how that's indented to the left, and then 52332. The codes in between 52320 are indented, but then when you get to 52332, that one is not indented. So I want to make sure Tracy Johnson got that. 52320 is not indented. 52332 is indented. I'm sorry, is not indented. 52320, 52332 are both standalone codes because they're not indented. So Tracy Johnson, you got that? 52320 is a standalone code. Then it has some kids underneath it. And then 523332 is another standalone code. Okay, yeah, listen. You see I got this little lamp here that I have to turn on to make the page a little brighter. So, and here's the other thing that I have that I always remind myself of. The standalone codes typically start with a capital letter. The indented codes start with a lowercase letter. You see that? Okay, so whenever you have an indented code, just remember that it relies on the description of the standalone code up to the semicolon. So let me give you some examples. 52320 is a standalone code. So that code utilizes that entire description. Cystourethoscopy, including ureteral catheterization with removal of a ureteral calculus. Let's go down to 52325. That's indented, which means we need to read the description of the standalone code up to the semicolon. Cystourethoscopy, including ureteral catheterization with fragmentation of a ureteral calculus. You see how we're not using both codes, we're just getting the description of the standalone code up to the semicolon and then dropping down and read our code. So we're not reporting both codes, but we're just reading the description up to the semicolon. So 52327, cystourethoscopy, including ureteral catheterization, then with suburetic injection of implant material. Everybody got that now? So whenever you have an indented code, you have to read the description of the standalone code up to the semicolon. Okay, I want to make sure you guys got this, so I'm going to give you an example, and I'm going to have you type out the description for me. Okay, 1 second. Okay. Look at code 31510. 31510. 31510. Three 1510. Everybody there yet? Now, what is the full description of 31510? Keeping in mind, we have to go to the standalone code. We get the description up to the semicolon and then add the component for our code. So what's the full description of 31510? So whenever you're looking at an indented code, it relies on the description of the standalone code up to the semicolon. So Tracy made a little mistake. Tracy added information after the semicolon. So it should be laryngoscopy, indirect, stop, there's a semicolon, with biopsy. You see that? Okay, let's do another one. This is a concept that is typically very difficult to grasp, and it's just so important to me that you guys understand it. So go over to code 298 298 298 298 29873. 29873. 29873. And give me the description of 29873. So arthroscopy, knee, surgical, Tracy Meyer. Don't forget about the semicolon. That's where the description ends. And let me explain to you why it makes a difference. Do you notice that 29870 is arthroscopy, knee, diagnostic? 29871 starts our arthroscopy, knee, surgical codes. So what would be the description for 29876? 29876. So you don't have to actually, the semicolon is just informational only for us to let us know to stop reading and drop down to the rest of your code description. That's why that's there. Tracy Johnson must be a typist. So 29876. We'll wait for Tracy Meyer to finish typing. So arthroscopy, knee, surgical, synovectomy, major 2 or more compartments. And if you notice, 29877, 29879, 29880, 81, 82, 83, 84, 85, 86, and 87 all rely on that initial description from 29871. Okay, everybody understand that concept? Yes, you only report the indented code. The reason that it's indented is to conserve space so that they don't have to report that sentence over and over again. Because think about it. If they have to print out that sentence over and over again, think about how big the book would be. Does that make sense? So we don't report both codes. We only are reporting our indented code that shows what our doctor actually did. Okay, let's go back to the index. And let's go over to the letter A in the index. Okay, so the coding process always begins in the index. You got your main terms, which are in bold print. Underneath your main terms, you have your subterms. Your subterms are either going to give you a range of codes, which is separated by a hyphen, or a couple of codes, which are separated by a comma. So it's like either look up this entire range of codes or look up this code or this code or that code. And then based on the code description, select your final code, based upon what's documented in the record. So we never, ever, ever code from the index. And that's pretty much true with all coding manuals. We never code from the index. All right, so when you are looking through the medical record and you're trying to decide what you're going to code, look for action words like excision could be a main term. Biopsy could be a main term. Incision can be a main term. Removal can be a main term. Oh, something of note. Very, very, very important. The root operations and all that business from ICD-10 PCS does not apply here. A repair is a repair. An excision is an excision. A removal is a removal. So all those 31 root operations, they don't apply here, okay? I had to point that out. All right, let's see what else I wanted to tell you. Again, I only got about 20 slides, but key things I wanted to point out as you journey into the CPT this week. There are references that we can use with CPT coding. In a previous class, you learned about coding clinic. You guys remember coding clinic? You know how to get to coding clinic inside of 3M? Okay, so coding clinic is for ICD-10 CM PCS, or there's a coding clinic for HCPCS. We, in this class, want to look at CPT Assistant, and you'll notice CPT Assistant is right here. That's one reference that will prove to be very helpful for you, and I'll explain why in a second. The other reference is the shortcut to the CPT lay descriptions. This is a part of Coder's Desk Reference. And what this guy here does, I love the shortcut to the CPT lay descriptions. What it does is give you the English description of that procedure. So like you read the description in the CPT book and you're like, yeah, okay, I still don't know what that means. Coder's Desk Reference, the lay descriptions, gives you the English version. So I got two examples for you. CPT Assistant, why would I want to use this? Well, in a few weeks, and I'll give you guys a copy of these slides. In a few weeks, maybe 2 weeks, you're going to be coding surgery. CPT Assistant put out an article November 2008 that's called Procedure Report Coding Tips. How I found it, you can see here that first I clicked on the binoculars there, and then this little box came up, and then I typed in CPT Assistant, November 2008, and then I scrolled down a little bit and I found my article, Procedure Report Coding Tips. This is an excellent article because it walks you through dissecting an operative report from a CPT coding perspective. So when you get to CPT coding, must read article. All right, Coder's Desk Reference. Why do I like Coder's Desk Reference? Coder's Desk Reference, let's see if I can make this bigger. Coder's Desk Reference gives you the English version of code. So for example, 33510 to 33516. Coronary artery bypass is initiated, I can't read that, with a single 2-stage venous uptake tube. The saphenous vein is either harvested from either leg. The vein may also be taken from the arm, the back of the leg, or a cadaver. Then it just goes on to tell you, it goes on to tell you all the things that are taking place for those procedures. And just to kind of solidify this, let's look up 33510 and tell me if you can see the benefit of using the Coder's Desk Reference. 33510. You guys see that? So you see how 33510 in the CPT book says coronary artery bypass vein only, single coronary venous graft. Yeah, it's a cabbage, but do you see how the Coder's Desk Reference gives it to you in plain English what the doctor is doing? So for all of your surgery codes, definitely this would be a resource that I would tap into. Definitely easier to understand. So CPT coding, what do you need to know to get your accurate code assignment? Number one, you got to know how to abstract the information from the documentation. You got to know your medical terminology and your anatomy. What you don't know, look it up. You have to use resources. CPT Assistant, Coder's Desk Reference are resources that you can use to assist with accurate code assignment. Knowledge of how procedures are performed. If you're reading a report, you don't understand it, watch a YouTube video. Watching a YouTube video will help you understand visually what that physician is actually doing. And then the other thing, and I can't remember if this is covered in the first couple of weeks of class, but I'm just going to mention it anyway. You also have to know about the National Correct Coding Initiative. I believe that that's probably discussed in one of the chapters for this week. But the National Correct Coding Initiative is a program that the government established to prevent unbundling. Unbundling is where you use 2 CPT codes and you should have only used 1. For example, laparotomy, and the patient also had an appendectomy. A laparotomy is opening the abdomen. Appendectomy is removing the appendix. In order to remove the appendix, you got to open up the abdomen, right? So the Correct Coding Initiative, one of its primary focuses is detecting when someone is attempting to unbundle. Okay? I know that that's covered in this class. It's also covered. Are you guys taking your insurance class yet? HIT 230. It's covered in there as well. Okay. All right. So let's code. Let's code. First scenario. We're going to go back to the index. And we only got 6 cases. I promised my husband I would not be on here all night. So we only have 6 cases we're going to look at. And I wanted to just walk you through 1 case for each of the chapters, the sections. So the 6 sections, 6 cases. Don't worry. I'm going to guide you through each and every step. So, evaluation and management. Patient was seen in the emergency department after she burned her hand with scalding water. An expanded problem focus history and exam were performed, and medical decision making was of low complexity. So where do we begin? There's a couple of ways that we can attack this, but for now, let's go to the main term of evaluation and management. Main term, evaluation and management. Subterm, emergency department. There's more than one way to look this up. I'm just taking you through this path. Main term, evaluation and management. Subterm, emergency department. What range of codes are you given under main term, evaluation and management, subterm, emergency department? Oh, that Tracy is a fast typer. That Tracy Johnson, fast typer. Okay. 99281 to 99288. Now, the next step, we're given a range of codes. Oh, it's a man. Is Tracy Johnson a man? I'm sorry. I'm sorry. I didn't know. See, I can't see you and you can't see me. I could have been a man too. Okay, so now, I got it now, Tracy, don't worry. Now, let's go and look up our range of codes. Now remember, this is an evaluation and management, so those codes are up front. So let's locate the range of codes 99281 to 99288. Not that many men in our industry, so it's good to see some men enrolled in our classes. I tried to teach my husband coding and he said it was boring. Oh, okay. So here's the key thing with evaluation and management. Most, not all of the codes, not all of the codes are based on key components, which are known as history, exam, and medical decision making. So in looking at 99281, is everybody there yet? And remember, evaluation and management is up front. So I think Tracy Meyer, you might not have been here earlier. So go to the very front of the book and look for 99281. The evaluation and management codes are up front and they're out of numerical order. Oh, Tracy Johnson, what page is it? I think you guys have the same book. No. 99281. And I can't give you guys the page number. Mine is 22. Look around, look in your book somewhere between 18 and 22. 99281. Okay, everybody on page 22 now? Okay, so let's pause for station identification just to make sure everybody's on the same page. First thing, you read your scenario and determine what main term you're going to use in the index. We were coding evaluation and management, so we went to evaluation and management. Under evaluation and management, we found emergency department. Across from emergency department, it told us to look at 99281 to 99288. Evaluation and management codes are at the front of the book, so we went to the front of the book, now on page 22, and we found 99281. Everybody understand that process we just went through? Okay, all right, no worries, no worries. I knew one of the Tracys did, but I didn't know which one. Okay, so now as you're looking at 99281, 282, 283, 284, 285, do you notice that they each have 3 bulleted items underneath them? Okay, those are known as components. With evaluation and management, there are most of the codes, not all, have 3 key components that are known as history, exam, and medical decision making. So let's see. Of these codes, which has an expanded problem focused history, an exam, and low complexity medical decision making? Nine 99282. I need my staples button so I can say that was easy. Okay, so you guys just successfully coded an actual case. Okay, let's do another one. So we're going to go back to the index. Back to the index. Okay, Helena is joining us, so we're in our CPT manual. We're actually coding a few cases. So now, this is an anesthesia case. So remember how I said that the more you code, the more you will know which main terms will work? With anesthesia, and hear me well, this is very, very important. With anesthesia, your main term has to be anesthesia. When you're coding for the anesthesiologist, your main term has to be anesthesia. So now locate anesthesia in your CPT index. The index is in the back of the book. Locate the main term anesthesia. And since Helena is just joining, you guys can tell what page it's on. $7.49. Okay. Helena, you have your CPT book? Okay. You're on page 749? Okay. So, with anesthesia coding, there's a limited amount of codes because the physician really isn't getting paid to do the surgery. They're just getting paid to drug the patient up. So, main term, anesthesia. Subterm, tympanoplasty. So under anesthesia, go in alphabetical order to the subterm of tympanoplasty. And what code does the index give you? Tracy Meyer, you got to work on your typing skills. Helena came in and beating you typing in the answer. Only been here for 60 seconds. Okay, so now, question for you guys. I want to see if you've been paying attention. Can we code from the index? No, we can never ever code from the index. So now we have to verify that number up front. 00, what was that number? 00120. So it's going to be after evaluation and management, before surgery, when you get the page number. Now, I don't know what year version everybody has, if you have 2015, if you have 2016, so I'm not going to give out the page numbers. I have 2016. So Tracy Meyer was the first to type this time, page 54. And so 00120 says anesthesia for procedures on external, middle, and inner ear, including biopsy, not otherwise specified. One thing that you need to know is the word that you saw in the index may not be verbatim what your code description says. Does that make sense? It's not going to be verbatim. So don't look for it to say the exact word verbatim, especially with anesthesia. So 00120. Now, anybody think we should use 00126? I want to try to trick you. And can't trick Tracy Johnson, can't trick him. 00126 says tympanotomy. Our patient had a tympanostomy. Ostomy versus otomy. See the difference? It's a different procedure. All right. Hey, you just coded 2 CPT services. Let's do another. So, as we go from one scenario to the next, we go back to the index. So go back to the index. Okay, Helena, go ahead and ask your question. So go back to the index. So after we code one scenario, we go back to the index. It says including biopsy. So whether or not it was performed, that code includes biopsies. But it's kind of a general category for procedures on the ear. So this is the one thing I want you to know. The codes in the anesthesia section are not dead on for the procedure because the anesthesiologist is not getting paid to do the procedure. They're getting paid to drug the patient up. So if you were to go and look for the actual tympanostomy code, those would be, you know, tympanostomy versus there would be a biopsy of the ear code. It would be that specific. Whereas anesthesia codes, they're very limited and they just really focus on getting in the right area. Okay, next case. Incision and drainage of suppurative hydradenitis of the arm. Now, let's stop here. What are the 4 ways that we can look up a CPT code? I want to see if you guys were paying attention. The 4 ways to look up a CPT code. Anatomic site is 1. Procedure or service. Synonym, eponym, abbreviation. And then lastly, the condition. All right. Now I can bring my slides back up. Okay. So, incision and drainage of a suppurative hydradenitis. So, remember I said earlier, there is no magical list that tells you how or what terms to use. It's really by trial and error. So let's see if condition works. Locate hydradenitis. Okay, hydradenitis, main term, subterm, suppurative, incision and drainage, and what 2 codes do we need to look up? Tracy Meyer says, you're not going to leave me behind. 160 to 161. So next step, we have to go and look up 160 to 161. So we go back to the front. And let's see. What is the difference between 160? Uh-oh. Let's practice. Let's practice our indented. So, what's our correct code? And Tracy Meyer says, I will not be left behind. What is our correct code? See, Helena, Tracy Johnson, he was like typing so fast, like a transcriptionist, like really fast, beating Tracy Meyer. So, Tracy's trying to, she must have put her glasses on. So 160 is the correct code because 160 says simple or single, 161 says complicated. So Helena, one part that you miss, which is very important, is that whenever a code is indented, it relies on the description of the standalone code above it up to the semicolon. So if we were to use code 161, the full description would be incision and drainage of abscess, skip all that stuff in the parentheses, complicated or multiple. Whenever you have a code that's indented, and you can go back and listen to this part, Helena, whenever there's a code that's indented, it relies on the description of the standalone code above it up to the semicolon. We don't use both codes. We just use our code. This concept is done to save space. So instead of them writing over and over again, incision and drainage of abscess, carbuncle, suppurative hidradenitis, cutaneous or subcutaneous abscess, cyst or furuncle or paronychia, they listed it once. The first code, simple or single. The second code, complicated or multiple. Don't go past the semicolon. All right, next case. X-ray of the abdomen. Abdomen, let's see. AP view of abdomen reveals no abnormal soft tissue mass, gas, shadows, or calcification. Liver and spleen not enlarged. Main term, X-ray. Main term, X-ray. Main term, X-ray. Under X-ray, subterm is abdomen. What's your range of codes? Uh-oh. Okay. 74000. Yes, Tracy. Tracy says she will not be left behind. 74000 to 74022. Okay, so the next step is to locate those codes and determine, you're looking at the descriptions between them and determining which one is the correct one. And again, we got that indented business going on. We got that indented business going on. So then the question is, which one of those codes accurately reflects what our patient had done? So let's see. Uh-oh, I see all kind of different answers. Interesting. Well, let's see. This is what you got to do. You have to read the descriptions of those codes and figure out which one is the right one. So 74000, radiologic exam, abdomen, single anterior posterior view. So far we did have a single anterior posterior view. 74010, anterior posterior and additional oblique and cone views. Did we have that? Additional oblique and cone views. No. Okay. Complete, including decubitus and or erect views. Did we have that? Okay. 74022. Complete acute abdomen series, including supine, erect, and decubitus views, single chest view. So our final answer is 74000. So basically what you're looking for is the number of views and what they looked at. So, but primary is the number of views. Okay. And they didn't do decubitus and erect views and supine and all that. Yeah. So I know you guys have not done radiology before. I mean, we're just in week 1, but I'm just giving you one example from each chapter just to kind of, that's why it's called a codathon. All right, let's keep going. Number 5, thromboplastin time partial, PTT in plasma. So let's go back to our index. See, you guys already know how to code, right? You already know how to code. All right. There's a couple of ways to attack this. But let's go to I see you guys typing. Thromboplastin, let's see. I wasn't going there, but remember, there's more than one way to skin a cat. So you can go to thromboplastin. I'm going to go with you. And under thromboplastin, subterm, partial thromboplastin time, PTT, 85730 to 85732. So then you're going to turn over to those codes. Eight five seven 85732. Final code is do 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 do. 85730 is correct. All right, next up. Patient underwent therapeutic injection of intramuscular kanamycin sulfate, 500 milligrams. Which code would be assigned? So we're back in the index. We're back in the index. Where do you guys want to begin? Do you want to go to injection? Do you want to go to therapeutic? I can tell you that therapeutic is not going to work, so injection. Okay. All right, and so when you get to injection, what is subterm? IC, intramuscular. Under injection, I see intramuscular, and it gives you two codes to look up. Ours was intramuscular. Okay, so it tells us to look up 96372 and 99506. So 96372. Okay, now I want to throw in a final component to this. And I know you guys are like, we read about the HCPCS system, but how are we supposed to how are we supposed to code HCPCS when we don't have a HCPCS book, right? So in your doc sharing area of our course, let's see, I can't see what you guys are seeing. Okay, in our doc sharing area of our course, there is a HCPCS index right here. Alphanumeric HCPCS code index. If you go there, we had a drug that our patient was given, right? It started with a K, right? Care or something. Let's see if we can find the HCPCS code in here. I didn't look it up earlier, but we're going to see if it's here. It is here. Let me make sure you guys can still see my screen. You guys can see my screen? Okay. So it's either between J1840 or J1815. So this part right here is just the index because that's all that's listed here. You see, this is like just the index, right? So you're like, okay, well, how am I supposed to figure out what's the difference is? So write those two numbers down, J1840 and J1850. And then I'm going to go back to doc sharing, and I'm going to look for, there is another document. Oh, HCPCS record layout. I'm sorry, I didn't look at these beforehand. Oh, I don't like this. Okay, give me 1 second because I have a HCPCS list somewhere. So just hold on 1 second. Let me think about where it's at. 1 second. I got a list somewhere on my computer. I mean, obviously you can Google it, but I have a list of HCPCS codes in a file, and I'm going to share them with you. I just got to figure out where it's at. If I cannot find it and really quickly, I'm going to have to email it to you guys. But I have a HCPCS file that is, oh, it might be in this other class. I'm sorry, I have so many folders on my computer. Unbelievable the number of folders I have. I have an Excel spreadsheet that has HCPCS codes on it. And I remember using it last term. So let's see if I can find it. Oh, I know exactly where it's at. Give me 1 second, guys. I'm getting close. I had to really think about where it's at, but I'm gonna upload it so that you guys can have it. And then I'm gonna open it up. Okay, I got too many windows open. Let me just close some of these windows on my screen here. Almost there, guys. Almost there. Okay, so let me share this document, and I'll upload it. Okay, so this is a spreadsheet that actually has the 2016 HCPCS codes and then the 2016 HCPCS modifiers. That index that you saw is pretty much what you can expect for looking up the CPT or the HCPCS codes. But what you will do is, and what was that first code we had? Because I can't remember. You can go over here. Make sure you guys can still see my screen. Okay, go over here where it says find and select. Click on find. Type in your code, which you told me was J1840. And it will page down to that. And it says J1840 injection kanamycin sulfate up to 500 mgs. And then what was the other code? J1850. Okay, where are you? Is that the same number? Oh, J1840 and J1850. Okay, so one says 500 mgs, the other one says up to 75. So let me go back to our scenario and see which one was the right one. It was 500, right? So correct coding would include both of those, okay? That's why I wanted to show you guys that. Okay, so let me give you these files. Here's the PowerPoint that I used on tonight, and then the HickPix file that I just showed you. I'll give you that as well. So what you can do is use the index in doc sharing to look up what the range of codes would be, and then you can use that file that I just gave you guys to look up the codes. Fair enough with that one? Good deal? You lost Helena? Okay, so that is